Good afternoon and thanks for joining us for today's Healthline 3. I'm Courtney Butts and today we're joined by our featured guest, Dr. Charles Otu with the Willis-Knighton Center for Pediatric Gastroenterology. Thanks for joining us.
Thank you, Courtney.
Absolutely. So tell us a little bit about what you do in pediatrics at Willis-Knighton.
Well, I'm a pediatric gastroenterologist, basically meaning I deal with diseases and disorders within the GI tract. I've been with Willis-Knighton for at least 11 years now. I currently lead the GI service. Mainly specialized in advanced endoscopy, which is more of a complex endoscopic management of kids with GI problems.
All right, yeah, and we're about to dive in and talk a little bit about what to look for as far as symptoms and maybe treatment options that you can help with those conditions. Okay, well, and if you are new to Healthline, Healthline 3 is where we like to focus on a way to live a happier, healthier, and pain-free life. We'll be taking your calls and answering your questions in just a little bit, and we'll take those questions live in the studio. We'll be opening those phone lines in just a little bit, but as a reminder, when you do call, make sure you're in a quiet room with that TV turned all the way down so we can hear your question. That number to call will be on your screen in just a little bit, but it's 318-219-4569. And today we are talking about the advanced treatment of abdominal pain in children. So, what are maybe some of those common causes of chronic abdominal pain in kids? Because this might be something pretty common, but what are those common causes?
Yeah. So, with pediatric GI practice, belly aches or abdominal pain is the most common presentation. I will tell you that it's probably about 75% of patients we see, and that's their main complaints. The question is, is it just pain within the stomach itself or within the other organs in the abdominal cavity? We tend to see a lot of patients who come in with belly aches, and majority of the pain is not, the pain is real, but not necessarily because they have a disease within the GI tract. They do have a pain disorder within the GI tract, and that's almost about 75% of cases. In 25% of cases, though, it's typically there's a disease going on or some kind of abnormality within the organs in the GI tract. And so you could have, a patient with, say, an ulcer, within the stomach or within the small bowel causing pain. And this ulcer may be peptic, meaning that it's either acid-induced or, peptic induced. Or it could be allergy-induced inflammation causing pain in the belly aches, and that's something that we see very often. It could also be related to the gallbladder, just not functioning well, or there may be stones in the gallbladder. Could be inflammation within the pancreas, and sometimes it could also be just a load of stool, within the GI tract causing pain. So, there are just diverse, multiple causes of pain that we tend to see in these kids.
Yeah, okay, and a lot of times we talk about chronic pain or acute pain or something that's happening in the body. Can you explain the difference between those terms? I know that it can kind of be a little confusing.
Right. So chronic pain, basically, in the medical world, any kind of pain that's been lingering for more than 3 weeks is considered chronic pain. And so chronic pain may last, beyond 3 weeks, several months, years, or even forever. It's pain that someone's had for a very long time. Typically, the pain may be insidious, meaning that it's very much slow. It's kind of rises very slowly to a peak, and it gets to a point where it may affect function. It may affect sleep, school, not eating. Acute pain is typically abrupt onset pain, and that's an indication there's something going on that really needs to be taken care of immediately. it could be secondary to other conditions. Say you have a sore throat, and that can give you an acute bellyache. Once the sore throat goes away, the bellyache goes away too, and normally it shouldn't last more than 3 weeks. You could have a UTI, urinary tract infection, that gives you bellyaches too. And once the UTI resolves, the pain goes away. And then there is what we call acute recurrent abdominal pain. This is pain that typically may last hours to days and then resolves, gives you some time period where you're just back to your baseline. You just don't feel like there's anything wrong, and then it kicks in again, you know, and it just keeps recurring. And that's recurrent abdominal pain.
So both situations you probably want to, you know, address.
Yes.
Right. Especially if it's acute, you might want to get to the emergency room quick.
Yes. Yes.
Yeah.
Definitely. If it's acute, you probably want to see your primary physician, because a lot of those acute pains may be handled by your primary physician without you necessarily seeing a GI specialist, unless, let's say, an acute pain from a huge ulcer that might need our attention. But normally chronic pain is where you really need to see a specialist like myself to try and figure out what's causing the pain and how we can address it.
Right. Okay. And so you mentioned one of your specialties is the endoscopy, right? So tell me a little bit about that and when someone would need that done.
Well, so an endoscopy is basically a procedure where we use, you know, long, narrow tubes that typically has a light and a camera at the end, and it's able to magnify what's going on within the GI tract. And you know, these tubes have channels within it. We typically call those channels working channels that we're able to put instruments through to either take biopsies or to fix problems that needs to be fixed within your GI tract. And so these long tubes are passed through the oral cavity, you know, down into your GI tract, your digestive system. And if you look at the image here, so you know, you could pass the tube all the way down through the esophagus, get into the stomach, get all the way past the stomach into the small intestines as deep as you can to look for disease.
Right.
These tubes can also be passed down through the anus all the way through the colon, which is the large intestines, all the way back into the small intestines looking for disease. So that is endoscopy. That's generally endoscopy. And that's a little bit different from advanced endoscopy, which is more sophisticated or complicated, and requires some level of specialized training.
Awesome. Well, thanks for sharing that. And we have our first caller, Kara. Thanks for joining us. And what is your question for Dr. Otu?
Hi. I'm wondering, what is colic in infants, and how's a new mom to know if baby's crying is colic or something else?
Well, so colic is it's a medical term, you know, basically given to infants who are just very irritable, uncomfortable, and crying for several hours. And it almost seemed like there's nothing you can do to resolve the discomfort or calm them down. And sometimes some of these kids, you may have to put them in, you know, a ride or a car and drive them around, and just that might relax them. So, you know, in the medical world, it's not totally clear what causes these kids to be colicky. Sometimes it's just the type of formula they are consuming. Might not, their GI tract might not be tolerating that formula. There are other times where it may be more neurologic. You know, it may be triggered from the brain more than from the GI tract. But majority of the time when we see these patients, it tends to be, you know, the formula they might be on. Their feeding regimens, they may be having, you know, reflux-like symptoms that just makes them uncomfortable. And so we have conversations with, parents, try and figure out, what's the feeding regimen, what formula are you using, are you drinking too much cow's milk that just making the kid a lot gassy, and hopefully making changes to this their diet can be helpful. There are other times where we need to use medications to decrease the kind of spasms that we think may be causing their symptoms. There are times where you can do all these interventions. It doesn't necessarily make much of a difference, and you realize that this is more than just a GI tract problem, and may need to see maybe a neurologic specialist to tease things out.
Yeah.
Well, I guess my other question is, should we wait for the baby to outgrow it, like back in the day, or should we rush to make an appointment with you?
Yeah, majority of the time. So, most babies grow out of colic. Typically by the time they get to about 3 months of age, it stops.
Yes.
And so, a reassurance if the baby is growing okay, the baby feeds okay, you're not seeing any blood in the stool, the baby doesn't have a fever, gaining weight, appropriately, just reassurance and making some mild modification in the diet is okay, and hopefully by 3 months of age, the symptoms typically goes away.
Okay, great answer. Thank you so much.
Thank you.
Thanks, Kara, for joining us. And if you're just joining us and you have a question for Dr. Otu, we're talking about pediatric gastroenterology and things that might be going wrong or awry in the digestive system. And you can give us a call, 318-219-4569. That number is also on your screen. So you were talking about endoscopy before we took the caller, and do you use that a lot of times to diagnose these conditions?
Yes. Yes. So I think endoscopy initially was not a therapeutic tool. It was more for diagnostics. And basically, when all other testing has not been effective in figuring out what might be causing the pain, then we do these endoscopies to try and get a diagnosis. So that's one part of it. Now with a lot of advancement, we do a lot of therapies, with endoscopy as well. An example would be, if a child has swallowing difficulties or pain, and has had X-rays and blood work, and nothing can be teased out, and comes in to see us, a lot of times the next step is endoscopy. And there may be where you go in and you realize this child has an obstruction in either the esophagus or down in the stomach, and that needs to be relieved. And you can do that with that endoscopic tool.
Wow, okay. And so you use it to look for multiple different things.
Yes.
So let's talk about, we talked about peptic ulcer disease or something like that. So tell me, what is a gastric ulcer? Like, what are you looking for? What are those symptoms, and how do you treat it?
Well, a gastric ulcer basically means there's a compromise, in the lining of your GI tract. The GI tract, just like your skin, should not be bleeding. Right? Anytime there's bleeding, that just means there's some kind of compromise. And so when you have a gastric ulcer, you have a sore, a wound within your abdomen. Gastric means the stomach. So the ulcer is within the stomach itself. And basically it would cause pain. It would cause a lot of pain immediately you eat. You feel the pain. It actually prevents you from wanting to eat. It causes you to get full very quickly. Because of that break in continuity of the lining, you eat and you feel nauseated, and you would throw up. There are patients who the ulcer might have a blood vessel very close to it that could bleed, and so they could throw up to the point where they see blood actually coming out. And when the ulcer is very severe, it can cause you to bleed to a point where you actually see blood in your stools, or you see your stools looking really dark. So those are some of the symptoms patients need to look for, or to identify and realize that, hey, this may be an ulcer going on. I need to see a GI specialist.
Right, okay. And so you mentioned endoscopy as a diagnostic tool, but can it also be therapeutic as well? Okay.
Yes. So, yes, and I think I mentioned where you may have an obstruction, and so you could use the endoscope to dilate and open up the obstruction. There are several therapeutic treatments or therapeutic options with endoscopy. And so let's say you have, I see patients, because I do advanced endoscopy, I'm primarily leaned into patients who have pancreatic disease or gallbladder disease or biliary duct disease. And on this screen, when I talk about pancreatic disease, I'm talking about the pancreas is right behind the stomach, and so you may have, you may have belly aches that's right above your belly button, and there's pain that you can feel right there, and the pain is originating from the pancreas. The pain may also be originating from the gallbladder, or even within the bile duct. And the bile duct, as you can see, it's a very small channel. These are very small channels that can get obstructed depending on what may be going on. If you have a stone in your gallbladder and the stone tries to jump out of your gallbladder, it may obstruct the biliary duct.
Right.
And by doing that, it will cause a lot of pain. And so in situations like that, yes, I can go in with the endoscope, which is the tool that I just described,
Right.
and be able to get into that small space and clear out that space. If there's a stone in there, I can get that stone out. If it's more of a stricture meaning that it's a narrowing that just doesn't allow good function, I can open up the narrowing with a balloon. I can dilate, open it up, and put a stent or a connecting tube across it to allow it to do the function it needs to do.
All right, very cool. So since we're talking, let's get to our caller first, and then I'll hold my question until we come back.
Yes.
And I'll let you get your earpiece in so we can hear. But Betty, thanks for joining us. And what is your question?
Okay, I have a great-grandbaby. He was born premature. He was 2 pounds, a little over 2 pounds. And so now he's over 6 pounds. And he is 2 months and 3 days. How old do they be when you start giving them baby cereal?
Baby food? Is that what you said? Did you hear the question?
No, I did not.
So premature baby born and 2 pounds. It's now up to 6 pounds, 2 months old, and you're wondering when to introduce baby food. Is that correct, Miss Betty?
Yes.
Well, how premature is this baby?
He was born August the 19th. Which is mine had C-section. He was premature born, so
I'm sorry, I think
now he's over 6 pounds.
How premature? I don't think I hear.
So born in August, but when was the original due date?
Yes.
The original due date was October the 20th.
October the 20th, so just 2 days ago.
Oh, okay.
3 days ago, wow.
Okay.
So born in August. So
Okay, so it's about 2 months,
2.5 months.
premature. Yeah, so typically 2 months premature. I don't consider those babies as too premature. They still have majority of the organs that are needed to function as normal babies, and so typically, what our recommendation is as to the time of starting baby foods and all that, you want to make sure your baby has a good neck control. If the baby's neck is very floppy, you don't want to feed. So if at 4 months of age, 5 months of age, baby has really good neck control, can hold his or her neck, that's a good time to start introducing baby foods if you want to.
Yeah.
Yeah.
Okay. So kind of dependent
Okay.
on how they're progressing
Yes,
and growing.
yes,
and
definitely.
Stuff.
Okay, so 3 months would be for him to be too young to give baby food.
Yeah. So she's asking 3 months would be probably too young.
Yes,
Mhm.
I definitely would not do this at 3 months of age. Shoot for 4 months to 5 months of age.
Thank you so much, doctor.
Thank you, Betty. And if you're
Thank
just
you.
joining us, if you have a question, just give us a call, 318-219-4569. Okay, so going back to the pancreas and maybe to our little diagram.
Yeah.
So we were talking about the bile duct and pancreas at one point. So pancreatobiliary disease.
Yes.
It sounds scary. Tell me about it.
Yeah, it sounds scary, but and really it's scary, but basically what it is that's just a name given to disorders that involves the pancreas, and I showed you where the pancreas is, and then the gallbladder and the biliary duct. The pancreas is a very important organ in the body, and basically its main function is it has two functions, one being where it controls your hormones, blood sugars and stuff, to regulate your sugars. And then also it produces digestive enzymes. So basically your carbohydrates, your fats, and your proteins, you need your pancreas to produce these enzymes to break down the food. And so if it's not functioning, you're definitely going to have some problems. The gallbladder by itself is more of a storage organ, and it has these connecting tubes that allows whatever is stored to be released into your digestive tract. And basically what it stores is bile, right? And bile is also required for digestion, especially with fats. Anytime you consume fats, bile is released to kind of break down the fat, make it more water soluble so it can be well digested and absorbed. And so if you have problems with your gallbladder, you would have problems with fat absorption and belly aches as a result. The bile duct, which is part of the pancreaticobiliary, where the bile duct basically just connects the gallbladder to the intestines, and so it allows bile to flow down, and then you get your bile within the GI tract and good digestion occurs. So anytime there is a disease within the gallbladder, within the bile duct, or within the pancreas, then we have a condition either called pancreatitis, pancreatic disease, gallbladder disease. It could be a stone-related disease, or it could be a function-related. The gallbladder is just not functioning well, or there could be a stone actually obstructing the bile duct. So these three comprises of what we call pancreaticobiliary. And part of the reason it's such a complex disorder is because they work together. The bile duct, the bile duct opening joins the pancreatic duct opening, and so if there's any problem with that opening, it can affect both of those ducts.
Gotcha.
That makes it, and because they have very small ducts, it makes it very complicated dealing with them, and you have to be really well experienced to manage patients with that kind of disorder.
Gotcha. And I can imagine some symptoms
Yes.
associated with that.
Yes.
Maybe, a lot of stomach issues.
Yes. So, typically, gallbladder-related symptoms would typically be where you have pain in the upper part of your abdomen, and then typically may move towards your back, or it may be towards the right side of your abdomen, because that's where the gallbladder and the pancreas is. And so this pain, you may have this pain that comes and goes. It may be radiating towards your back or radiating towards your shoulders. Those are classic signs that, hey, you may have a gallbladder related problem, or you may have a pancreatic problem. The pain may wake you up in the middle of the night to the point where you have to vomit to get relief. Sometimes gallbladder pain might be transient. It's one of those pains that are recurrent. So it comes and then you have relief for maybe a few days and then you get another bout of the pain. It may be because you have a stone in there, the stone is trying to jump out, and once it gets to the neck of the gallbladder, it gets obstructed and it triggers that pain. And then once it falls back in, the pain goes away. So when you start to have these symptoms, you definitely want to see a GI specialist to help figure it out.
Gotcha. Okay, and we have just a couple of minutes left, but do you have any success stories that you'd like to share, maybe from patients that you've worked with?
Oh yeah, I've had really good outcomes with a number of patients that has been very much fulfilling. I would give you an example of a 9-month-old baby who I think this was about a year ago, had unfortunately drank a chemical that was alkaline based and had eroded the entire esophagus.
Oh no.
And so when I saw this child, the esophagus was almost closed off. And one of the things we did initially was put a tube across the esophagus to be able to continue feeding, because the rest of the GI tract was functioning, but the esophagus had so much ulcers, the child could not feed directly through the mouth. And gradually through our interventions, using the same, scopes and working channels within the scope, I've been able to gradually dilate the obstruction to the point where now, and obviously a child needed to go through about 6 sessions of dilation, almost every 3 to 4 weeks. And at this point, the child is feeding orally,
Nice.
and the esophagus is quite wide opened.
Awesome.
So that's one good story that
Yeah.
makes me feel really fulfilled,
That's awesome.
when you're able to provide these interventions to patients, you feel really good about it.
Absolutely.
The second story is a young teenager who I think was suicidal and took almost about 40 tablets of ibuprofen.
Oh wow.
That ultimately led to a huge ulcer within the lower part of the stomach, and did not come to our attention early. And so by the time I saw this child, she was about 3 to 4 weeks out and was just throwing up all the time, could not
Right.
eat, got full very quickly. And so through endoscopy, we realized the kid's stomach was obstructed. And so the outlet here, which is the gastric outlet, had been completely obstructed.
Wow.
And so
we have just about 20 seconds left.
And so we had to quickly dilate, and this kid also had to go through several dilations.
Okay.
And now she's fine. She's actually
Great.
not coming for her appointments anymore,
All
and
right.
tolerating
Great,
her
good
meals.
job.
So
Well, awesome.
this is a great specialty
Yes.
and opportunity to help others.
Thanks for sharing. All right, that number is right there on your screen if you wanted to call him, and we'll see you next time.